gastroenterology consultants of San Antonio. We'll be talking about hemorrhoids today. A brief presentation, hopefully patient-centered. So if anyone who joins has any questions, feel free to interrupt and go ahead and ask. So let's get started. So what are hemorrhoids? Hemorrhoids are dilated vascular channels between the anal mucosa and underlying internal anal sphincter. So, just kind of briefly about anal anatomy, there's an image on the next screen that will help you visualize what exactly is going on in your rectum, specifically in the anus. As I mentioned, these are dilated vascular channels. The image on the bottom here gives you an idea of where the hemorrhoid channels are located. As you can see, there's three main groups of columns that we focus on whenever we're intervening for hemorrhoids, particularly. There's the 6 o'clock and around 1 and 10, 11 o'clock as well. Now, I will say that hemorrhoids are part of normal anatomy. Most patients think of hemorrhoids as pathologic, and technically they are. Everyone has these anal cushions in the rectum that maintain rectal continence, prevent accidents, prevent, whenever you're passing gas, you're not having bowel movements, right? So those anal cushions do provide some sort of function. However, in some patients, those anal cushions do enlarge, and that's when we really start calling them hemorrhoids. So as you can see on my slide, those anal cushions do contribute to 15 to 20% of that resting pressure in the anus that kind of prevents accidents essentially. So this is the image that I was referring to give you an idea of what's going on as far as anatomical depiction of what hemorrhoids are. There's two types of hemorrhoids that I like to focus on, internal hemorrhoids and external hemorrhoids. Most folks will just think of hemorrhoids as one entity, but there is a separation of internal and external, mostly being an anatomical separation. As you can see on this image here to the right, there's a little kind of squiggly line there that is the dentate line that separates the external from the internal hemorrhoids. So the internal hemorrhoids, as I stated, are located above the dentate line. As far as why they develop, usually a consequence of low tissue support and then prolapse of the tissue. Some of the exacerbating factors include trauma from straining, from passage of hard stool and constipation, and also spending a long time on the commode. On the other hand, external hemorrhoids, go figure, are located below the dentate line. Couple of points I'd like to make about internal hemorrhoids. Going back to that, we can grade internal hemorrhoids based on the amount of prolapse. So this image on the right here is a good depiction of that. So as you can see, grade 1 hemorrhoids are really just located above the dentate line. And as you increase in the grade, the more you can see more prolapse of the hemorrhoids. So when you see a colonoscopy report or a note that describes the grades of hemorrhoids, that's basically what we're describing. And one thing to keep in mind, if you have a hemorrhoid, an internal hemorrhoids that's prolapsing out and you can't push it back in, that would be a grade 4. Whereas a grade 3, you can actually manually reduce the hemorrhoid back into the rectum. And it's freely mobile essentially. So who's affected and what are the symptoms of hemorrhoids? So as I said, hemorrhoids is a pretty common phenomenon. More commonly we see it in the elderly, less commonly in younger folks, but we do see in patients with both constipation and bowel habit issues, straining, and even on the opposite spectrum, we see it in patients with diarrhea. Common things that can exacerbate hemorrhoids: pregnancy. So a lot of pregnant folks do have issues with hemorrhoids. Just with that increased intra-abdominal pressure pushing down, right? I mean, that can definitely contribute. We see it in folks that work in certain occupations, such as truck drivers, folks that are seated for prolonged periods of time. We see it in weightlifters. So a lot of folks have hemorrhoids, as I said, a normal anatomical issue, but again, which can result in symptoms. Now, symptomatic hemorrhoids occur in about 4.4% of the population based on a large US-based study. But the prevalence, as I mentioned, increases with age. Usually we see a peak in the 40s and 50s. Now, getting down to what symptoms are related to hemorrhoids. Now, painless bleeding is probably the most common complaint that we see here in clinic. Hemorrhoidal bleeding is usually what we call nuisance bleeding. It rarely leads to significant anemia or drops in your blood counts. Usually patients will say, hey, there's a little bit of bright red blood in the rectum, in the stool, excuse me, and on the toilet paper. One thing to kind of keep in mind is a little bit of blood does look like a lot in the toilet bowl and in water in general. So sometimes, but rarely, hemorrhoidal bleeding can result in dark stool, usually when there's a large amount of bleeding and there's a lot of clotting. Anal itching and pain is usually pretty common from hemorrhoids, but pain is more so severe with thrombosed hemorrhoids. And we'll go into the treatment options for thrombosed hemorrhoids. Essentially what that means, there's a big blood clot causing the hemorrhoids to swell. Tissue bulging around the anus, pretty common. And then obviously leakage of feces and difficulty cleaning after a bowel movement. We see that quite often as well. And unfortunately, this is just a consequence of the prolapse and skin tags that can form as a result of hemorrhoids. Now, how are they diagnosed? More than often, your history. When patients come into clinic with complaints of rectal bleeding, the history alone is indicative of what potentially could be resulting in that source of bleeding. The medical history is very important. Basically, also I mentioned there's other sources of rectal bleeding as well. So the history is important in that sense that it helps narrow down our differential. If other testing is warranted, we would be able to talk about that as well. A digital rectal exam, something we can easily do in clinic, is also helpful, particularly for external hemorrhoids. Unfortunately, we're not able to visualize the internal hemorrhoids as well with the rectal exam. And that's where the endoscopy comes in, which is essentially a tool that we have in a clinic setting as well, that I use pretty often to visualize internal hemorrhoids and also anal fissures, which often can be confused with hemorrhoids. But one thing to kind of clarify with hemorrhoids, they don't cause as severe pain as fissures. Fissures usually the pain is much more pronounced than bleeding. And then lastly, a flexible sigmoidoscopy or a colonoscopy, which is an endoscopic procedure where we can actually visualize the hemorrhoids. So the image here to the bottom left is actually an image of the rectum looking back at itself. Here you can see a little bit of inflammation there. This is what we call internal hemorrhoids. This delineation between the white and the red is the dentate line. And then on the other hand, this image here to the right is a depiction of external hemorrhoids. So when do you seek medical care? So as with anything, if there's persistent symptoms, definitely want to seek care. So persistent rectal bleeding or even anemia. As I said, it's pretty rare for rectal bleeding to cause anemia. So if there is anemia, that's something that you want to get evaluated for. Severe rectal pain, as I mentioned, not very common for hemorrhoids, except if they're thrombosed. So you want to be evaluated for an anal fissure or something else going on. If there's ever a sensation of a lump or a mass, definitely get evaluated. Any change in bowel habit, especially as we age, if there's any significant change and hey, my bowels have been significantly altered, I'm getting more constipation or more diarrhea, whatever the case may be, getting evaluated is important. Any constitutional symptoms like fevers, chills, anything concerning for any infection, and any positive fecal occult blood test or stool testing looking for blood definitely needs to be evaluated. So how are they treated? I mean, the most common question that I get asked in clinic is, how do we fix this? Easier said than done, I will say that. Hemorrhoids, as I said, are part of normal anatomy, and when they get exacerbated, they can flare. They come and go. So dietary modification is really the core of a lot of these treatment options. Adequate fluid intake, fiber supplementation, usually the first line. Metamucil or Citracel to meet your daily fiber needs. We need about 25 to 35 grams of fiber a day in our diet. Excuse me. And the fiber supplements help us get there. Unfortunately, our diet nowadays, we're not able to get that on a regular basis. This heterogeneous class of drugs called phlebotomics has been studied in improving hemorrhoidal symptoms. So this image here to the top left is actually an example of a phlebotonic medication, diosomine complex. It's somewhat of a vitamin that has been shown to improve some hemorrhoidal symptoms. I don't use it too much in my practice, but like I said, whatever helps. So this is something that has been studied. Topical therapies, anti-inflammatories, and emollients, so forth, analgesics has been used. So there's a lot of over-the-counter medications that we often prescribe, at least from a medical perspective. However, long-term therapy with these sort of medications usually probably best used as needed, because it can predispose folks to allergies and sensitization, essentially your body getting used to those medicines. Now, lastly, sitz baths, something that we simply can do at home. And they actually sell these in any over-the-counter pharmacy. But the core of this being, you want to soak your bottom in some warm water for 10 to 15 minutes, about 2 to 3 times a day, to help reduce any of that inflammation. The key is not to add any soap or bubble bath or any additives, because it can definitely irritate the hemorrhoids more so and cause itching and inflammation on its own, rather than reducing inflammation. Now, going more into treatment options, some of the office-based or non-surgical treatment options are listed here. I want to clarify that these are mostly for internal hemorrhoids. A lot of folks have external hemorrhoids, but unfortunately, we can't offer a lot of these therapies for external hemorrhoids, since the nerve fibers that control the external hemorrhoids are a little different. So the sensation's a little more profound for external hemorrhoids. So if we were to place a rubber band on an external hemorrhoid, it would be very, very painful. Compared to an internal hemorrhoid, which is on the inside, as I mentioned previously, it's not going to be as noticeable from a pain sensation standpoint. So rubber band ligation, essentially the theory behind this is kind of tacking down the lining of the colon by causing scar tissue and lack of blood flow that results from the rubber band being placed. Generally, we'd place one band in each office visit for 2 to 3 visits moving forward, aiming for those columns of hemorrhoids that I mentioned in the first couple of slides, which are the most common locations for the hemorrhoids. Sclerotherapy, which is another option where we inject this irritant into the lining of the colon to predispose, again, scarring. Infrared coagulation is another option. And then cryotherapy, which has really fallen out of favor. And lastly, surgery. As I said, surgery is an option. Usually in my book, considered a last resort. Even when you talk to colorectal surgeons, they'll mention that surgery really should be a last resort. Not because of the complications of surgery, which again can happen, but mainly because of the recovery time. It's pretty painful. It's a 2 to 3 month or week rather recovery time. Particularly because of the location of where the hemorrhoids are, right? So recovery time is the main thing that most surgeons are concerned about. But if anyone's interested in that a colorectal surgeon would be the one to talk to, the physician to talk to about that. So can they be prevented? As I said, hemorrhoids, and I keep saying this, hemorrhoids are part of normal anatomy. So it's not that we can necessarily prevent them, but we can definitely reduce any exacerbating factors. So any triggers, particularly constipation or even diarrhea or any change in bowel habits, definitely can prevent hemorrhoids. So that concludes my presentation. I'm here on the questions slide. If anyone who's joined the presentation since I began has joined and has any questions, feel free to ask at this point.